I'm Dr. John Cole. I'm a pediatrician.
My name is Melanie Underwick. I'm an infectious disease physician.
My name is Sarah Heineman, and I work at Missoula Public Health. Currently, I'm the Director of Health Services.
My name is Laura Williamson. I'm the state epidemiologist.
My name is Erica Baldry. I am the current section supervisor for the Infection Control and Prevention and Healthcare Associated Infections section.
Measles is one of the most contagious viruses known, and it has very distinct symptoms that present in a specific order.
Measles typically starts with a fever, a cough, a runny nose. You can get red eyes and you get a rash. It really starts up here in the hairline and goes right on down. And it's a distinctive rash. It's a flat, sort of a light pink rash that goes all over your body. And then you are contagious before the rash hits, which is also makes it dangerous because you don't even know that you're sick. You have measles brewing in your body, and then you go and do your daily business, but have unknowingly spread this virus.
Measles is an airborne virus, and this happens just by talking like I'm talking with you all right now, or coughing. Coughing is a big part of measles as well. So when we think about keeping our staff safe in the clinic in my pediatric practice, all healthcare workers need to be wearing N95 masks to protect themselves from being exposed to measles. So unvaccinated people actually have a 90% chance of getting measles if they're exposed. And one single infected person with measles can infect up to 12 to 18 people. And this is because the virus can last up to 2 hours in the air or on surfaces after somebody has coughed. So the population that would be at highest risk of acquiring a bad case of measles would be children under the age of 5 years old, and adults. The complications, beyond the symptoms that we went over earlier, are vitamin A deficiency, which we'll talk about a little later, but vitamin A deficiency can lead to eye damage and blindness. There's also a very unique thing about measles where it actually causes something called immune amnesia. And what this means is the measles virus actually can cause an immunodeficiency and make you more susceptible to other bacterial infections. So that could come in the form of pneumonia, diarrhea, ear infections. And diarrhea and ear infections actually can happen up to 30% of cases of people who get measles. Pneumonia has been shown to occur in up to 5% of cases. And then the more severe side effects or complications of measles, 1 in 5 people who get measles will be hospitalized. So that's about 20%. And encephalitis, which is when the brain swells, occurs in about 1 in 1,000 cases. And death can occur from measles in 1 to 3 out of 1,000 cases.
The risk factors for acquiring measles would be anybody who does not have the vaccine. So babies who are under 6 months old, they can't get the vaccine yet, so they're highly susceptible. Older people without the vaccine or people that are on chemotherapy are highly immunocompromised. Pregnant ladies can't get the vaccine, and so if they haven't had it already, they're at a higher risk to get it. And if you don't have the vaccine, pretty near almost all people who get exposed to the measles will get active measles.
Since measles is caused by a virus, supportive cares are really our only option, and that would include intubation if we have secondary pneumonia caused from measles. Oxygen would be a part of that too. Diarrhea, like I had mentioned, is a complication. So we might need to do IV fluids to rehydrate a child or an adult, and then fever and pain control. But it's really supportive cares for the majority of ways that we can treat measles.
Prevention is the main treatment in the case of measles. Even though the vaccines we had mostly for most of us were in our infancy, childhood, with 2 vaccines, we remain immune to it throughout our adulthood. The measles hasn't mutated that way, just like, say, the COVID virus does and the flu, where we need to get immunizations every year. The measles doesn't act like that.
So measles is reemerging in the United States because we have seen a precipitous decrease in vaccination. So the decreasing vaccine rates will decrease herd immunity, and now we're well below that 95% vaccine rate that's necessary to keep measles out of the community. So that's why we're seeing cases in most of the states across the United States, and that's why we're dealing with this problem that should honestly not be an issue because we have the tools to prevent this virus from causing any harm or death to any person in the United States.
There's been a lot of false information in the media regarding vaccinations that started with people thinking there was a correlation with it, autism and vaccines, which has not been proven. So remember, correlation does not equal causation. So in the fall, you'll see pumpkin spice latte increase throughout Starbucks. But also in the fall, you see increase of flu cases. So you could say the flu and the pumpkin spice lattes cause each other, but it's not true. Correlation isn't equal to causation. So more autism was being diagnosed during the time people were getting the vaccines of childhood that are recommended, but there was never any data to suggest that it actually caused autism. So there's been a lot of false information there. We did develop herd immunity when a certain percentage of the population is vaccinated. We all get protected so that those that can't necessarily get vaccines, that have these immunocompromising situations, or you're pregnant in some cases, we protected them by having herd immunity. All of us had it that could get it. But because there's all this misinformation and people are hesitant about it, it's now dropped our herd immunity level to a point where it's becoming more prevalent.
So the MMR vaccine is a combination vaccine that has measles, mumps, and rubella. And a little fun fact is that this combination vaccine was created by one of our very own Montanans, who's Dr. Maurice Hilleman, in 1971. Prior to that, there were single antigen vaccines, with the first measles vaccine in 1963, mumps was in 1967, and rubella was in 1969. And the benefit of combining these into one vaccine was getting one shot for 3 serious diseases. And we currently have 2 formulations available here in the US, one by Merck and one by GSK. And then there's a third one that's called MMRV that has varicella added to it, which is for 12 months to 12 years of age.
Measles vaccine is known as a live vaccine. So a very small amount of live measles that has been taken away some of its virulence patterns through researchers in the lab is injected into your body. So your body then makes antibodies to fight that. Your body remembers the measles through these antibodies that lie dormant in your body. So if you get exposed to the measles later in life, these antibodies are already formed. They know what to do. They attack it and they can kill it.
So even though measles is a new disease that Montana is having to work towards controlling, we do not expect that the spread of measles is going to be like it was during COVID-19. And that's because there is a good proportion of the population that has immunity against measles. And so what we're likely to see with this measles activity or measles outbreaks is that we're going to have pockets of measles activity, and it's going to be mostly among communities or groups of people that have low vaccination coverage.
several themes kind of emerging in our responses. One being individuals trying to approach this as if it was COVID-19. And so one question that's come up even is, if I place source control on the patient, then I don't have any exposures, right? And the answer was yes with COVID, but the answer is no with a highly infectious airborne agent. And so that I think is one thing, just trying to kind of transition our mindset out of COVID-19, but what are these standard core infection prevention steps that we can take when we have an airborne pathogen? Because this would be applicable to any airborne infectious agent, right? I also think that we've had some very large mass healthcare exposures that have resulted in press releases having to go out with, double digit, almost triple digit exposure numbers, which is pretty large when you're talking about public health response and then having to contact all those individuals. So I think if we can stop the exposure from occurring in the first place and have a plan to do so, and then know what to do if somebody enters our facility, because best laid plans, we still could have an exposure occur. A facility could do everything right and we still have an exposure occur. And so then it's, how do we respond to those exposures? And then what infection control mitigation strategies had we implemented to reduce our risk? We may not have a zero risk, but I feel a lot better with a lower risk than a high risk where staff only wore gloves. I mean, that was one scenario where we had a facility say, we thought we did the right thing. We put them in a room we don't usually use and we wore gloves.